So just let me know once you can see me live, and we will start our today's session for important image based question. So it will be just like talking and knowing the important questions from your NEET PG for your future coming NEET PG examinations. Right, so myself Dr. Shivam, I am a resident in ENT and head neck surgery. So currently I am doing my COVID duty, but what I thought is my duty should not hamper your preparation. So I thought to arrange a rapid revision for images for your NEET PG and coming mid AIIMS coming AIIMS examinations. So the problem is that I don't have pen with me, so I'll be just illustrating you, and you won't find any difficulty. Just let us see this first figure. If means this is a figure from your recent examination, what you can see here is a bulged out tonsils, uvula being deviated to other side, and there is congestions in the tonsil. So they had asked you what treatment you will give. So before treatment you have to find what is the diagnosis. Now different types of questions can be framed in and around deep neck spaces abscess. So what they had asked in that year, it was peritonsillar abscess. Why peritonsillar abscess? There are some important signs that you need to fetch from your question. So one important sign is the inflamed nature of the picture. So here you can see tonsils are inflamed, the tonsillar fossa and the tonsils anterior pillar, these are inflamed. Patients will be presenting to you with toxic signs of fever, pain, odynophagia and all. So this is your infection in the peritonsillar space. Peritonsillar space means between the tonsillar capsule and the tonsillar bed or the superior constrictor muscle. So there is a space where the infection and collection of pus occur. Now how you are going to differentiate it from parapharyngeal abscess? Why this is not a parapharyngeal abscess? If I ask you this straightforward question, will you be able to tell me why it is not a parapharyngeal abscess but peritonsillar abscess? In both the scenarios, you will get the tonsils pushed up to medially, that is towards the midline. Uvula will be deviated to other side. But in parapharyngeal abscess, these inflammation, this redness, congestion, the toxic signs, the odynophagia that is there. So basically, the clinically you will find that your tonsils, your the anterior pillar will be appearing as normal in parapharyngeal abscess. Why it is so? Because the infection is in parapharyngeal space. So if you see this image, which is just a schematic diagram to show you different spaces, this is your tonsil. So can you see my pointer? So I think you can see my pointer. Yes. So this is your tonsil. This is your peritonsillar space. And behind this is your parapharyngeal space, this. So if there is inflammation in this parapharyngeal space, what it will do is it will again push the tonsil medially. But now as the infection is not related with tonsils, it will not be congested, it will not be red, angry looking. Here also the tonsils would be pushed, but not due to infection in peritonsillar space, but due to infection in parapharyngeal space. So you need to see the clinical picture, you need to examine the oral cavity to differentiate between both of them. Now what about perivertebral, means prevertebral abscess and retropharyngeal abscess? How you are going to differentiate? So both these prevertebral abscess and retropharyngeal abscess will present to you in the posterior wall of pharynx, that means posteriorly. What difference you will get is this prevertebral space or the prevertebral abscess will be a midline swelling, while the retropharyngeal abscess space will be either right or left. The basis is the anatomy. If you see this prevertebral space, it is a space that is bounded by the vertebra posteriorly and prevertebral fascia anteriorly. So this is your prevertebral space. So it is a continuous space. Any infection, any pus collection will present to you with midline swelling and all other features of abscess. But in retropharyngeal abscess, here the LR fascia fuses with the buccopharyngeal fascia and result in division of the two space, right and left, and that is why retropharyngeal space abscess will be either side of the midline, either right or left. Another thing is there is one space called danger space, and why it is called danger space? Because this space which lies between the prevertebral fascia and LR fascia, any infection in this space may spread to your pleural, means may spread into your thorax. It communicates with the lung pleural cavity. So that is why it is called danger space, right? And here you can see your ramus of mandible, medial to which is medial pterygoid, lateral to it which is your masseter. This is your parotid gland. Here the nerves are 9th, 10th, 11th and the carotid sheath. So if this figure is asked in future, you can tell it. If any question, clinical based question is asked in future, you can again explain the diagnosis. Another picture which was given was from the dissection of temporal bone, that is your cortical mastectomy and posterior tympanotomy. What they had asked you in this picture of cortical mastectomy is, they had asked you this, they had labeled this as A and asked you to identify this structure. So this ivory bulge which you can see in the mastoid cavity is lateral semicircular canal bulge. If you see the orientation, this is your anterior, this is the posterior, superior and inferior. So here only what you need to see for your future questions is the boundaries and the probable questions that they can ask from this picture, because now they are more surgical oriented with the questions. So if we see the boundaries for cortical mastectomy, and you should know that the McEwen's triangle and the triangle of attack are two different triangles and have two different boundaries. So McEwen's triangle, you all know that it is a landmark for your mastoid antrum. Can anybody of you tell me what is the boundaries of triangle of attack where we drill for cortical mastectomy? So I can see your comments. If you know, just type yes, otherwise I'll tell you. So cortical mastectomy, the triangle of attack is used to drill for cortical mastectomy, and if you see, the superior boundary is your tegmen plate, that means dural plate, above which is the dura. Anteriorly is spine of Henle and the posterior canal wall, right? This is your posterior canal wall of external auditory canal. Posteriorly, or you can say postero-inferiorly, is your sigmoid sinus bulge. So in this area, superiorly you can say the triangle of attack is your inferior temporal line. Actually, after you drill in that inferior temporal line, you will reach this dural plate. Okay, anteriorly is your spine of Henle and posterior canal wall. Postero-inferiorly is sigmoid sinus. So this is the boundary of triangle of attack. Now here you can see a space and a star mark. So what is this? This is basically a procedure that is called posterior tympanotomy. In posterior tympanotomy, what we do is we drill in the facial recess to enter the middle ear from the mastoid cavity. So why we do it? One important indication you all know is for insertion of cochlear implant electrode. Another important MCQ that is related to is what is the boundary? What is the boundary in which we drill for the posterior tympanotomy? So it is very clear once you see this image. So again, the landmarks or the boundaries for posterior tympanotomy is your laterally will be chorda tympani nerve or the tympanic annulus. Medially will be your facial nerve, that is the vertical segment of facial nerve, and superiorly is comment me. I want it to be interactive so that you can recollect what all you know. Recollection of things is very important. Once you study, try to recollect, try to discuss it with your friends. It will go into your permanent memory, right? So superiorly is incudal buttress or fossa incudis, right? So if you can see my arrow, this is your fossa incudis or incudal buttress, which houses the what it covers. Why it is called fossa incudis or incudal buttress? Because it is housing, it is over the short process of incus, so it is covering that incus. Okay, and here you can see very clearly the incus, the part of incus which you can see from the mastoid cavity side, right? And again, this is your lateral semicircular canal, ivory colored bulge. Another thing is, doing a cortical mastectomy is just a play of games. So we surgeons say that while doing the cortical mastectomy, it is very essential that you identify the colors. What colors? Basically, superiorly you will find pinkish color due to dura. So whenever you are near the dura, you will find it, the color of the bone changes to little pinkish. Posteriorly will be little bluish due to sigmoid sinus, right? Lateral semicircular canal will be ivory white. Facial nerve again will be white, means bland white, and before you reach the facial nerve, there will be minute bleedings from the blood vessels that run along or above the facial nerve, right? So now another important thing that you can see from the posterior tympanotomy space is your round window niche. Here if you can appreciate, you can see a darker opening. So this is your round window niche, from where we will insert the cochlear electrode into the round window membrane and into the cavity. The final compartment is scala tympani. So this is a MCQ for you, that the electrode of cochlear implant is inserted into scala tympani. And another important MCQ that they had asked is brain stem implantation is done in. So brain stem implantation is done in, I want the answer. I have already talked about it. So brain stem implantation is done in, you can comment, it is done in fourth ventricle, where lateral recess of fourth ventricle. Okay, now again this figure shows you the lateral chorda tympani, medial is vertical part of facial nerve, and incudal buttress. Only thing that changed it, superior was here in the previous figure, now superior is the reversed. Okay, and now moving to another important question is, this figure is just showing an electrode being inserted into the round window through the posterior tympanotomy. Now another very important triangle is there, that is called Trotman's triangle. And why it is important? It is important because you use this triangle as an approach to enter into the posterior cranial fossa from the mastoid. So if you need to approach posterior cranial fossa pathology through the mastoid, you need to drill between this triangle, and that is why it is important for you to know the boundaries. The superior boundaries is a sinus, that is superior petrosal sinus. Posterior boundary is sigmoid sinus. Okay, posterior boundary is sigmoid sinus. This arrow shows you the sigmoid sinus. Superior boundary is superior petrosal sinus, and anteriorly is the solid angle. Solid angle is the where all the superior, posterior, horizontal semicircular canal, they bulge, they have one united point, that is called solid angle. So anteriorly is, say with me, anteriorly is solid angle, superiorly is superior petrosal sinus, and posteriorly is your sigmoid sinus. It is an approach to posterior cranial fossa through mastoid. Now Another important or future MCQ they can give you is this. They can give you this diagram, and in this magnified picture you can see a yellowish drum which is attached to the long process of incus. So can anybody tell me what is this drum which is being attached to the long process of incus? So I'll wait for some seconds and see whether you know this future MCQ or not. So it is a middle ear implant. Okay, so it is a vibrating middle ear implant. What it does is it does the amplification of vibration once any sound reaches through ear. So here what happens is the device that is externally placed, it creates a magnetic field, and this is your free floating magnetic transducer. So in the magnetic field it has coils, so it vibrates in the magnetic field which is created when the sound strikes the external device, and the vibration causes increased vibration through the ossicles, resulting in more intensity of sound reaching to the inner ear, and that is why it is functioning as a hearing aid. Why? Because it is intensifying the sound, but as it is implanted into the middle ear, it is called implantable middle ear device. The name of this device, which was first approved, is called Vibrant Sound Bridge, right? So Vibrant, I'll write the name. It is called Vibrant Sound Bridge. Okay. So yes, a middle ear implant is a medical prosthesis that is implanted in the middle ear mechanically, and it vibrates the middle ear ossicles mechanically. The device is known as Vibrant Sound Bridge. The external device is VORP, which is a receiver, and the internal device is Floating Mass Transducer, right? So you got this, and it is very important for your future MCQ. Now one 2-3 years back, one recent year question which was framed by which the board which I couldn't name, they had given a thickened nerve here, and they had asked to identify this nerve. So how many of you know the answer? So this nerve is basically, which is thickened here, is greater auricular nerve. Yes, so in conditions like leprosy, many a times you will see your patients presenting with thickened greater auricular nerve, and this is the thing they had asked you by pointing the arrow. So if you see this greater auricular nerve, it arises through the border of the medial border of the sternocleidomastoid, and goes and supplies the pinna. So basically a supply of pinna. And why it is important is, many a times during surgery, if you injure this greater auricular nerve, you will result in loss of sensation of the pinna. Like in parotidectomy, what we do is now is we preserve the auricular branch of greater auricular nerve so that the sensation doesn't get lost. In another surgery is rightidectomy, where this nerve can be injured. So your main function motto is to identify this nerve, which is called greater auricular nerve. Another important applied thing is, in cases of facial nerve paralysis, a long time, or in case of facial nerve injury, many a times you need to do cable grafting of facial nerve. That means you need to graft the facial nerve in the temporal bone if it is injured or cut, or a segment of facial nerve is diseased, or a segment of facial nerve is lost. Then you need to graft the facial nerve intraoperatively, and then the graft that you use most commonly is this greater auricular nerve. So this is also an important perspective of greater auricular nerve that you should know, that greater auricular nerve is used for facial nerve grafting. Okay, another nerve which is used is sural nerve. Sural nerve, which is present medially around near the medial malleolus, lateral malleolus, is the sural nerve. This nerve is also used, but as greater auricular nerve is locally available, you can just increase your postauricular incision to extract this nerve. So it is most commonly done. The diameter is also more or less similar to the facial nerve. So these are some important aspects of using greater auricular nerve as graft for facial nerve implantation. Now there was a scenario where you got a patient which was presenting with chronic discharge of ear. Diplopia means double vision, and the patient had presented to you with these long history of complaints. What is the next investigation you would like to do in your patient? So what you are suspecting with the history of diplopia, chronic ear discharge, retroorbital pain is you are suspecting a complication of chronic otitis media, that is petrous epicitis, and in this petrositis you are expecting a Grado-Nigo syndrome. So for diagnosing the petrositis you need a HRCT of temporal bone, without which you cannot see whether the infection has reached up till the petrous apex. So you need to do a CT scan, HRCT scan of temporal bone, and what all you get a triad of symptoms: ear discharge, which is due to chronic suppurative or chronic unsafe ear otitis media. Second is diplopia due to sixth nerve paralysis. So sixth nerve is abducens. So SO4 LR6, that means lateral rectus will be paralyzed, and that is the reason that your patient will present with diplopia. Retroorbital pain. Why this retroorbital pain is present? Because there is irritation of the Gesserian ganglion or the trigeminal ganglion at the petrous apex. Okay, so there is petroclinoid ligament which houses this Gesserian ganglion of the trigeminal ganglion, which causes the irritation, causes retroorbital pain. So diplopia due to lateral rectus palsy, retroorbital pain, and chronic ear discharge. So you need to find these three from the question your examiner provides and fetch to the diagnosis of petrositis as a complication of chronic otitis media. Now this is the another commonly asked question where a child will present to you with an opening above the tragus and at the crux of helix. So the first figure that you can see here is your figure for, tell me in the comment, it is pre-auricular sinus. But in the second picture you can see a opening somewhere below the lobule between the angle of mandible and below the ear. So this is something else. So can you tell me, the first one is preauricular sinus. I know most of you know, but can you tell me what is this, the second one? So this second one is called oral fistula. So both have different origins, and that is why both have different place of pathologies. This preauricular sinus is caused as an embryological defect in development. What defect? It is due to defective fusion of hillocks of His, which is formed by defective fusion of first and second branchial arch. And the colorectal fistula, which has external opening somewhere near the pinna, means below the pinna and above this angle of mandible, and an inner opening, if you see the name, which is called oral fistula. So another opening will be oral. Oral means in the external auditory canal, right? So it has two openings. One is situated in the neck, just below and behind the angle of mandible, means somewhere, sometimes above the mandible or below the mandible in the neck, and another in the external auditory canal. And why it is formed? Due to defect in the first branchial cleft. Okay, the first one was first and second branchial arch. The colorectal fistula is due to first bronchial cleft, right? So I think you got both of them. Now what is this clinical picture? The clinical picture shows you a hematoma oris or a cauliflower ear. You can also say it a boxer's ear. So what is the cause of it? It can be caused due to blunt trauma over ear, where the blood hematoma forms between the cartilage and the perichondrium. So this is a sterile condition mostly, but if it gets infected and cause perichondritis, then you need to intervene and drain the pus, and the treatment of choice for this perichondritis will be, do you know the name of the treatment of choice of this drug? It is ciprofloxacin. And by knowing that the drug of choice is ciprofloxacin, you can just guess the name of organism. So it is Pseudomonas. So Pseudomonas is the most common organism which causes the condition of perichondritis like this. Okay, now this is a clinical picture where your patient presented to you with painful eruptions near the ear, near the pinna, and a lower motor neuron palsy. So these all are pointing you towards Ramsay-Hunt syndrome, where you get a painful reddish rash with fluid-filled blisters in and around the ears, a very painful condition, and a lower motor neuron palsy. Ipsilateral, the thing you need to know is ipsilateral lower neuron palsy. So there is again a triad. So in medicine there are a lot of triangles. So a similar triangle is Ramsay-Hunt syndrome triangle, where you get a ipsilateral facial nerve palsy, ear pain due to the eruptions, and vesicles in the auditory canal and the auricle. So these, you know that herpes has a dermatomal involvement. So here along the facial nerve supply, these eruptions and these things occur. And why it occurs? Due to reactivation of the herpes zoster oticus. Okay, so I think you won't mistake it now. Yeah, yes. Now another very important question is, which was asked by them, is, so I think I'm still live. Yeah, okay. So the given below image in a patient with a history of road traffic accident, the options are Battle sign, Bisol's abscess, Sitili's abscess, Grissinger's sign. So I know you all know it is Battle sign, but what you need more to know is what all things can occur in the post-auricular region. Yes, it is seen in fracture of base of a skull, either from middle cranial fossa most commonly, and what all things you will get raccoon eye. You can get a CSF otorrhea, you can get post-auricular ecchymosis, that is Battle signs, and you can get a bluish tympanic membrane, which is a hemotympanum, right? So these all you will be getting as clinical signs in case of your road traffic accident causing a base of skull fracture. So raccoon eye, Battle sign, hemotympanum. Here a clinical picture is again shown to you with a glistening reddish post-auricular swelling. So tell me the clinical condition where you will suspect this. You all are answering great, and I want you to again answer this. So it is seen in acute mastoiditis. So the condition is called ironed out mastoid. Again, one more swelling is seen in the post-auricular region, where in case of lateral sinus thrombosis due to obstruction of emissary veins, you get edema over the posterior part of the mastoid, and that sign is called, you all know that sign is called Grissinger's sign. Edema over the posterior part of the auricle due to obstruction of the emissary vein caused by sigmoid sinus thrombosis as a complication of unsafe chronic otitis media. Okay, so it is called Grissinger's sign and not Gradeniger syndrome. Both are from G, but don't confuse. This is a sign called Grissinger's sign. That is a syndrome called Gradeniger syndrome. Now, again, a clinical picture you found in a patient who presented to you at OPD with complaints of decreased hearing. Upon further investigating, you did a otoscopy and found a bony hard swelling like this in the otoscopic picture. Upon taking the history, you found that he is a swimmer. So what condition you are suspecting? Yes, I am waiting for the answer. So what condition are you suspecting? Yes, it is exostosis. And why not osteoma? So basically you also need to see whether this swelling is bilateral or unilateral. So osteoma is a single tumor composed of cancellous bone located at the outer part of bony canal. Exostosis while is maybe a multiple growth located in the deep meatus, and mostly it is bilateral. So etiology is cold water swimmers, and history will be a symptom. Chief complaint will be hearing loss if the external canal is obstructed by the mass. So until and unless this mass is causing trouble to the patient, as these are benign, you are going to approach it by observation. That is conservative. But it is causing, if it is causing obstruction, if it is causing pain in the ear, if it is causing decreased hearing for the patient, conductive hearing loss, then what you can do is you can, under local anesthesia through the post-auricular approach or through the end-oral approach, you can elevate the tympanomeatal flap, drill this osteoma, that is the bony overhang, and again reposit the tympanomeatal flap. So main aim is to drill off this elevated and the extra bone that has grown there. Okay. Another otoscopic finding where your patient presented with chronic ear discharge but not too much pain. Here the patient is saying to you that he had a history of entering of water in the ear, after which he complains of itching in the ear. So very irritating itching in the ear with a otoscopic finding of this. So what you all think? So this is a condition of oto mycosis. Yes, newspaper like appearance or cotton buds. So here what you can see is, you can see some black dots in the white debris. So if I ask you the organism, this is most commonly Aspergillus, whether niger or fumigatus or candida. So mostly these three organisms cause otomycosis. So do you know the blackish colony that is formed here, the blackish balls that are seen here is formed by whether niger or fumigatus. So it is formed by niger. These black dots are specific for Aspergillus niger if they are very specific with the organism. The fumigatus forms a bluish type of colony. So it will be smoky green. Sorry, not bluish but green. It will be smoky green. So velvety powdery green type of colony in the ear, and the candida is very peculiar. It will be a beautiful white type of thing. So it will look beautiful, but it is very irritating for the patient and for you as a surgeon also, because it needs proper care and recurrent cleaning of the ear. So this is the candida, this one is Aspergillus fumigatus, and this one is Aspergillus niger. Okay, so I hope you are getting things. And this otomycosis is also another name of Singapore ear. Okay, so Singapore ear is again another name of otomycosis. Now this is a tympanic membrane, but there is something different with this tympanic membrane. Two different things you can see here. One is a thinned out transparent region, a oval transparent region here. So do you know what is this? This is basically a dimeric tympanic membrane or a healed tympanic membrane. And why it is more transparent than rest of the tympanic membrane? Do you know the cause? It is because the fibrous layer in the tympanic membrane. So you all know that the tympanic membrane has three layers: epithelial, fibrous, and the mucus layer. Means the mucosa layer that is continuous with the middle layer. So here the fibrous layer is absent when the tympanic membrane is healing by itself. If you do the tympanoplasty, it is again all the three layers are present because you have given the graft which is acting as a middle layer. But here the tympanic membrane is healed by itself and the fibrous layer is actually disorganized. More you can say, the more appropriate is, it is disorganized rather than absent. So that is why it is more transparent. Another peculiar thing that you can see here is this whitish plaque. So this is what? This is a tympanosclerotic plaque. So nowadays this otoscopic findings are very important for you, and that is why I have given these otoscopic finding, whatever they can ask, whatever question they can form. So blue tympanic membrane, one condition you already know, that is hemotympanum. Tell me the other conditions where you can get a blue drum. So another condition can be a glue ear, okay, or otitis media with effusion. One more condition it can be in cholesterol granuloma, and in many cases people say that in glomus tympanum, that is in glomus tumor, your tympanic membrane appears reddish blue. So if they ask you about blue drum, this hemotympanum, glue ear and cholesterol things are more appropriate than the glomus, because that glomus is reddish blue. Yeah, glomus is actually reddish blue, not totally blue. So that is why hemotympanum, glue ear are more appropriate answers for blue ear. But yes, if the question they have formed is like this, if they have given hemotympanum, glue ear, glomus tumor, all the above, then you will mark all the above, right? Another rotoscopic picture where you can see some vesicular eruptions in the congested tympanic membrane. So here you can see small vesicular eruptions. So this is a condition called bullous myringitis. And why this is so called? Because there are different small eruptions, and the causative organism now which is seen by culturing the fluid in this bulla is the Streptococcus pneumoniae. So now it is known that it is caused by the organism Streptococcus pneumoniae, right? So did you knew this? Now tell me the diagnosis of this otoscopic picture. Very common and very common in childhood, in child age. Patient will present to you that the ear is becoming heavy. It seems it is heavy and he is able to hear the sound less. Some days before he had some common cold, nose block and all. So what is this condition clinical? First of all, try to see what all you can see here. So in this otoscopic picture you can see multiple air bubbles and you can see some air fluid level. So yes, it is not ASOM, but it is otitis media with effusion. Yes, so it is air fluid levels which you can see. Okay. Now what is this condition? One thing is clear, it shows a perforation in the tympanic membrane. So I'm not explaining the parts of tympanic membrane because I think you must be knowing it. So this is the handle of malleus, this is the umbo, this is the lateral process of malleus, this is your anterior and posterior malleolar fold, and this part is your pars tensa. Above these anterior and posterior malleolar folds is your pars flaccida. And here what you can see is which type of perforation. First you need to define the perforation. So it is a central perforation. Central perforation is a perforation in the pars tensa surrounded by pars tensa. So it will be surrounded by pars tensa. When a perforation is called marginal, when the fibrous annulus is deficient. Whenever in a perforation the fibrous annulus is the whitish thickened part of the tympanic membrane. which houses it into the bony annulus. So once you elevate during the surgery, if you got any chance to assist any ear surgery, tell your senior or the surgeon to show you the fibrous annulus. So once you elevate the tympanic annulus, you will see that after in the end point where the tympanic membrane attaches to the bone, the bony canal, there is a cord-like whitish structure, and that is called fibrous annulus. So when this fibrous annulus is also degenerated, when it is absent, then you call the perforation as marginal perforation, right? And usually and mostly any ear with a marginal perforation will be a unsafe or squamosal variety of chronic otitis media. So from this central perforation, you can fetch a diagnosis of acute otitis media. So the newer classification, I think you all must be knowing that ASOM, CSOM has been changed to AOM and COM. So that means this suppurative thing has been changed. So now chronic otitis media is divided into mucosal and squamosal variety, right? So this eticoantral, tubotympanic are also changed. Chronic otitis media is divided into mucosal and squamosal. So if you go through that my videos, detailed video in the Unacademy platform, you will find this. So this mucosal has active, inactive and healed variety. The squamosal have active and inactive variety. So this is the newer classification that you should know, and chronic suppurative otitis media term has now been changed to chronic otitis media. So this is a chronic otitis media with a central perforation, and mostly if the ear discharge is absent, it is inactive mucosal chronic otitis media. So this should be your proper and complete diagnosis. Now in this tympanic membrane picture, you can see diffuse or you can see irregular margins of tympanic membrane perforation. So what etiology can it be? So it seems to be a traumatic etiology. So it is a traumatic eardrum perforation. And why it is important? Because traumatic eardrum perforation, if any patient charges someone with the criminal complaints, that because it amounts to grievous injury, so you need to see whether this perforation is healing or not. So you need to wait for 6 weeks, and if it doesn't heal, then it will amount to grievous injury or grievous hurt. But if it heals somehow spontaneously, then it will be your simple injury and not grievous hurt or grievous injury. So usually you need to wait for some time and observe for spontaneous resolution of this perforation. Now here is another beautiful picture which was presented to you by a child with complaints of conductive hearing loss, and when you did the otoscopy, you saw a pearl-like lesion through the intact tympanic membrane. So what is the peculiar finding was, it was the tympanic membrane was intact and it has a pearl-like structure through the tympanic membrane. So this is a congenital cholesteatoma. Why congenital? Because this congenital cholesteatoma has a criteria called Levinson's criteria. So Levinson's criteria, it says to you that there will be a white mass medial to the tympanic membrane. That means inside the middle ear cavity. Okay. The tympanic membrane, that is pars flaccida and tensa, should be normal. Not only intact, but they should be normal. There should be no prior history of any ear discharge or perforation. So these are the conditions for labeling a patient with congenital cholesteatoma. Okay, so congenital cholesteatoma, the cause, you know, there are many theories, among which the most popular is the presence of congenital cell rest, which gave rise to the formation of congenital cholesteatoma. But it need to satisfy these criteria to be labeled as congenital cholesteatoma. So they would mention in the question, as a child presented to you with this otoscopic picture where there was no history of otorrhea, there was no any otological procedure performed, and the white mass was seen through the examination finding, that is the otoscopic picture they have given. So they are not going to mention normal pars flaccida tensa and a mass. You need to see that image and take these 2 points from the history, that there is no otorrhea and no ear surgery. Okay, and then you need to mark the diagnosis as congenital cholesteatoma. Again, the other types of cholesteatoma are primary acquired and secondary cholesteatoma. So primary acquired cholesteatoma will give you a peculiar picture like this, where you will get a retraction pocket in the atic region, that means in the pars flaccida. Many a times you will get erosion of the atic wall. Okay, so there will be erosion of the scutum and a retraction pocket. So these primary acquired cholesteatoma, why I am saying this is because these occur through the formation of retraction pocket through the Prusac space. Okay, so this Prusac space is the route through which retraction pocket occur, and once this retraction pocket progress to an extent that it loses its self-cleansing property, the squamous epithelium starts depositing there, and due to this deposition of the squamous debris, the cholesteatoma starts forming, and then the cholesteatoma releases enzymes that causes bone erosion. So this is the pathophysiology through which a primary acquired cholesteatoma occur, and peculiarly you will get a picture, otoscopic picture like this, where there will be atic retraction pocket with squamosal debris or discharge, right? So this is a normal and this is a primary acquired cholesteatoma. So if this picture is given to you as an otoscopic picture with some clinical symptoms and features, you are going to mention it as squamosal variety of chronic otitis media, and that will be active or inactive based upon whether it is discharging or not. Whether this squamosal debris is discharging, then it will be active squamosal chronic otitis media with cholesteatoma, and if it is not discharging, it will be inactive chronic otitis media squamosal variety. Got it? Yes. Now, what is the secondary acquired cholesteatoma? So, regarding primary that I told, you can see here this invagination, this retraction going through the neck of Malleus through the Prusac space, and finally forming a blind sac from where now no more epithelium can be cleaned. And in secondary acquired cholesteatoma, there should be a previous etiology. That means there should be pre-existing perforation in pars tensa, mostly posterior marginal perforation. Okay, so there should be already presence of a posterior perforation through which either migration of squamous epithelium occur, or implantation of squamous epithelium occur, or papillary ingrowth occur due to improper ventilation. Okay, now coming to another important MCQ from the vascular supply of the littles area. Now first let us see the general vascular supply, the orientation. So you know that in the anteroinferior part of the nasal septum, which is a highly vascularized area, we get bleeding from here, and the area is called littles area. Most common cause is eye injury or the nose pricking in children. So the blood supply is from the both internal and external carotid artery. The internal carotid artery component is anterior ethmoidal artery, and the external carotid artery components are septal branch of superior labial artery, greater palatine artery, and sphenopalatine artery. Right? Now what question they had asked is two versions of question. One version was, which of the following artery does not supply this little area? So your posterior ethmoidal artery does not supply this little area. Another version of question was, which of the following artery is a branch of internal carotid artery supplying the littles area? So if you see this question, which of the following is not a branch of external carotid artery, or you can say a branch of internal carotid artery in the Kesselblake's plexus or the littles area plexus? So answer is anterior ethmoidal artery, which is a branch of internal carotid artery. So this question is a repeat from AIIMS. So it is not like I am framing it. They have already framed this question. So you should know this, that they are forming this type of questions from this part. Another plexus is Woodruff's plexus. So can you tell me the blood supply of Woodruff's plexus? So basically from Woodruff's plexus, bleeding occur in case of hypertensives. Okay, and where it is present? It is present just below the sphenoid opening, posteriorly, 1.5 centimeter above the posterior part of choana. So you know that sphenoid sinus ostium lies 1.5 centimeter above the choana, the upper limit of the choana, and that is where your Woodruff's plexus is present. So tell me the blood supply of Woodruff's plexus. So the blood supply is through the sphenopalatine artery. So sphenopalatine artery is also called artery of epistaxis. Now there was one question with oroantral fistula. Oroantral fistula can be caused by all except. Just tell me the answer. A, B, C, D. Dental extraction, carcinoma of maxilla, Caldwell-Luck operation, and maxillectomy. So this question I have already discussed. If you remember, the answer here is maxillectomy. Why? Because if you see the this oroantral fistula means a communication between the oral cavity and the antrum, maxillary antrum or the sinus. So it can be caused due to removal of this tooth. The cavity can be left, so it can cause a oroantral fistula. Caldwell-Luck operation, where we iatrogenically, means the surgeon creates an opening through the oral cavity into the maxillary antrum. It can also lead to the oroantral fistula, and carcinoma of maxilla due to erosion of the palatal bone can lead to oroantral fistula. But maxillectomy is total removal of this part, this one part of the maxilla. So there is no point of creation of oroantral fistula when the antrum is not present. You are removing whole of the maxilla along with the maxillary sinus antrum, that cavity, maxillary sinus cavity. So no point of fistula if you are removing whole of the maxilla, right? So answer will be maxillectomy. Now one question was with regard to polyp. So with regard to polyp, I'll give you a newer perspective with regard to diagnosis through CT scan. First, let us see what question they had asked. They had said or asked you that ethmoid polyp are characterized by all of the following except. So first, tell me the answer, then we can move to the CT scan picture, how you can diagnose this polyp once a patient brings a CT scan of nose and paranasal sinus to you in the OPD. Viral in origin, multiple, antihistaminics are useful, surgery is treatment of choice. Yes, I can see the comments. So if you see the ethmoidal polyps, they are usually arising from the ethmoidal air cells, and that means as there are multiple ethmoidal air cells, the polyps are multiple. The etiology is allergic etiology, and that is why antihistaminics can be given for the treatment. And the final treatment, the treatment of choice is functional endoscopic sinus surgery. Okay, so let us again go to our options. Multiple, yes. Antihistaminic useful, yes. Surgery is treatment of choice, yes. Viral in origin, no. These are basically allergic in origin, right? So this is a diagnostic nasal endoscopic picture showing you multiple ethmoidal polyps arising from the ethmoid sinus. What all you need to see is, this is your middle turbinate, here will be your nasal septum, this can be your bulla, from behind which you are getting ethmoidal polyp. Okay, so not very clear because this is a pathological image. Again, this DNA is showing you something else, a white, single white polypoidal lesion. So most probably, not very confirmatory, it can be a enteroconal polyp which is arising from the maxillary antrum going towards the choana and the anterior part of the nasal cavity. And you know this very basic difference that the enteroconal polyp, the etiology is infection. These are usually single, unilateral, trilobed, grows backward. Treatment is surgical, and in ethmoidal polyp it is multiple, allergic, bilateral. Why bilateral? Because it is allergic. Why unilateral? Because it is infectious. So one of the maxillary sinus can be infectious, but if it is allergy, it is a systemic disease, and then you are going to get bilaterally ethmoidal polyp, right? And the treatment for ethmoidal polyp is both medical and surgical. Now you have diagnosed seeing a diagnostic nasal endoscopy. Can you also diagnose this based upon this CT scan picture coronal cut? What type of pathology is it showing? Whether it is a enterogonal polyp or a ethmoidal polyp. Because nowadays we don't do any endoscopic sinus surgery without a CT scan. And in question, if they ask you, key, what type of cuts you will prefer before you do your endoscopic sinus surgery, you have to tell that you will look to the coronal cuts. Coronal cuts means like this. So it will be starting from here, here. Why it is so? Because these coronal cuts are the roadway, or you can say are the map to your sinus surgery. So these coronal cuts, it will start from here, right when you insert the endoscope inside the nostril. So you inserted the endoscope, you saw one CT scan cut picture, then you more inserted it inside, then another cut. So by seeing the CT scan, you can map out your endoscopic sinus surgery. So you are getting my point. You have to see each cut. So that is why we recommend very thin slices, that means 1 millimeter cuts of CT scan for nose and paranasal sinus, so that we don't miss any structure, any air cell through the CT scan. We should know each and everything before we do our surgery. So that is a characteristic of a good surgeon who knows the anatomy before he starts operating. So a surgeon which starts operating and then finds something abnormal is a very risky surgeon. With the advent of radiology, now every surgeon does pre-planning of his every steps of operation through the radiology. So you can get a HRCT CT scan, means high resolution CT scan of nose and endoscopics, this nose and paranasal sinus, and means plan your surgery. So if you see this picture of endoscopic sinus surgery, means of this endoscopic CT scan of nose and paranasal sinus, you will observe that there is some opacity in the maxillary sinus which is coming out through the widened maxillary ostium into the nose, and this is probably your inferior turbinate. So this is arising from the maxillary sinus, most probably a enteroconal polyp. Okay, and if you see this picture here, maxillary sinus are clear. The ethmoidal air cells have opacity. So black denotes air in CT scan. So here you can see mucosal thickening or polyp in the ethmoidal air cells. And how you can say it is ethmoid by this normal CT scan? If you see, this is just given to make you understand the normal looking of this nose and paranasal CT scan. If you see here, this blackish cavity is your maxillary sinus. This is your inferior turbinate, right? Bilaterally inferior turbinate. Here you can get the middle turbinate. What pathology you are seeing here is your middle turbinate is pneumatized. Pneumatized means air is present in this middle turbinate. And if I ask you, if I want to see whether you know that, what is the name for pneumatized middle turbinate? So I am seeing the comment whether you know this or not. What is the name for pneumatized middle turbinate? So it is called conca bullosa. So pneumatized middle turbinate is called concha bullosa, right? So another thing is these things are your ethmoidal air cells, and the biggest ethmoidal air cells is your bulla ethmoidalis. So this should be your bulla ethmoidalis. So here you can see this part is denoting to the ethmoidal air cell, and this big cavity is your maxillary sinus. This is your tooth, oral cavity or hard palate, and these two are orbit. Here you can see different intra-auricular muscles, medial rectus, superior rectus, and between medial rectus and superior rectus one artery emits from here, and that artery is anterior ethmoidal artery. So this is also an important question, that anterior ethmoidal artery emerges from the orbit between the medial rectus and the superior oblique at a conical projection called Kennedy's nipple and enters the nasal cavity. So this point is also important, that is called Kennedy's nipple, when your anterior ethmoidal artery enters from the orbit into the nasal cavity. So now after seeing the normal anatomy, you are better able to delineate that the pathology is in ethmoid sinus, and thus it is a ethmoidal sinus or ethmoidal polyp. Okay, so based upon the diagnosis you can plan out your treatment for the patient. And this sinus you can see is your frontal sinus. So bilaterally one frontal sinus septum is separating right frontal sinus from the left frontal sinus. Okay, this is your orbital cavity. This is your lamina papyracea, or you can not. This is your lamina papyracea. The medial wall of the orbit, the thin bone you can see is your lamina papyracea. Okay, so this is your medial orbital wall, and this is your cibriform plate. This is your base of skull or cibriform plate, which is most common site for the CSF rhinorrhea. Very thin bone here. So this is your lateral and this is your medial cibriform plate. You need not to know in that depth, but just know that this is your base of the skull. So while doing endoscopic sinus surgery, we try not to injure this part because it is very thin, and we do not, or not by mistake, we try to risk means jerkfully move the middle turbinate. Why? Because one part of the middle turbinate, if you see this, one part of the middle turbinate, that is the middle turbinate, has three parts: sagittal, horizontal, and coronal. So sagittal, coronal, and horizontal. So the coronal, the mid part or the coronal part, the sagittal part, actually the first part, gets attached to the cibriform plate. So if you move the middle turbinate jerkfully, it can lead to fracture of cibriform plate and can lead to CSF rhinorrhea. So you need to know this point, that one attachment of middle turbinate goes to the cibriform plate, and it is important for you to not to riskfully damage this middle turbinate to prevent iatrogenic CSF rhinorrhea. Okay, so I think we had discussed a lot for today, and just last question. This is an easy one and we'll end our session, and after the session do let me know how much it was useful for you, because it serves as a motivation for me to find time and be a part of you in your success journey. So I believe that you will make it this year, because the time is tough for everyone. I'm also doing my COVID duty daily, so it's quite a stressful time for all of us. The fear of getting infected is always there. The fear of making family infected is always there. So I hope that you remain healthy in this pandemic, in this phase, and get best out of you and get the best results in this NEET PG 2021. So do give your best whatever possible, taking your happiness, your health, and your mental peace. Okay, so you do not compromise on these things, because these things are the ultimate things which matter. So study well and be happy, because this is not the time that you should be too much stressful. So target sign is seen in spontaneous CSF rhinorrhea, traumatic CSF rhinorrhea, both or none. So I am seeing that Dr. Pratap, Dr. Nikhil have answered it as B. Yes, you both are right. It is a traumatic CSF rhinorrhea finding. Why? Because this target sign is formed due to two circles. One is the inner, that is caused due to blood. Another is the outer, that is caused due to diffusion by the CSF. So the blood will only be present if it has led to injuring the blood vessel. So if there is any injuring to blood vessel, if there is any fracture, then only blood will come. Because spontaneous occurs usually in obese male with increased or raised intracranial tension. Traumatic is due to any road traffic accident, or you are doing an endoscopic sinus surgery and you shaked the middle turbinate, or you took the endoscope and just while doing the clearing the opening the ethmoids, you injured the base of the skull or the cribriform plate. So then it can lead to traumatic CSF rhinorrhea, where you will get this target sign or the halo sign, where the CSF will be blood mixed. Okay, so I think I should end this session. It is already 1 hour, and do let me know your feedbacks. This is Dr. Shivam. Stay happy and do whatever you find good for you.